on the dais. Chair Ms. Yegna Priya Bharat, Joint Director Health, IRDAI. The panelists for the session, Mr. Anish Kumar, VP Enterprise Product Solutions, Cigna. Mr. Krishnan Ramachandran, CEO, Apollo Munich Health Insurance. Dr. S. Prakash, Executive Director, Star Health and Allied Insurance. Ms. Sheila Anand, CEO, Vidal Health TPA Private Limited. Ms. Anuradha Sriram, Health Benefits Towers Watson. Dr. Sudhir Nayak, President, Association of Medical Consultants. Dr. Mufassal Lagdawala, Chairman, Institute of Minimal Invasive Surgical Sciences and Research Center, Saifi Hospital. May I request the Chair to kindly begin the session? Ma'am, over to you.
Good afternoon, everybody. So we have a very distinguished panel over here, and we're going to be discussing about innovation in health insurance products. Friends, innovation is nothing new. Innovation was there in the industrial age, and today innovation is there in the information age. So innovation has always been there, and innovation is necessary and has to be there as well. What does innovation basically do? Innovation is nothing but a response to changing needs. And we've been discussing in the previous sessions about the needs of the customer. And in the context of health insurance, I think it's very important to be talking about the design of products that exist today and what innovations do we need in order to ensure that the customers are really covered or get the coverage that you're looking for. My team at IRDA, I made my team at IRDA recently analyze the trends in health insurance products. You're all aware that the IRDA came out with the health insurance regulations in the year 2013. And apart from keeping in view the interests of policyholders, the intent of the regulations was to provide a proper framework for not only regulating the sector, but also facilitate development. And product development is one of the areas we've really been focusing on. So if I look at the trends that took place in the last 2 years, or if I look at the health insurance canvas today, I basically see 400 products, pure health products. I'm not including the personal accident and the travel products here. I look at a sector that is rupees 20,000 crores in size. I look at a sector that has offered coverage to around 29 crores people. Of course, most of them are under the government schemes, but you also have a substantial number in terms of numbers, both under the group and the individual. So I think a lot has been happening on the health insurance front. It's the fastest growing segment today in the non-life sector, and the one that everybody is basically looking at. And I see separate health verticals set up in all the non-life companies. And at the regulatory office itself, we have a separate vertical set up for health insurance. So the kinds of product that we have today, of course, include the basic indemnity products, include the, the vanilla product that almost every insurer has, and then certain tweaking in the indemnity ones in terms of the kinds of diseases they cover, etc. I see benefit-based products. But what I see mostly is all of these cover events that basically happen. What we've been talking about, covering sickness and not really wellness, though there are certain products today which have come up with certain add-ons or riders or certain incentives for good lifestyles and such behavior. But I'd like to just mention the list that my team has prepared in terms of the new covers that have come up in the last 1 year or so. Today we have certain specific products which cover Parkinson's, Alzheimer's, and certain other terminal illnesses, which is really good. especially from the senior citizen point of view. Of course, most of the products have also offered today enhanced coverage because of the rising medical costs. Certain illnesses and treatments which were earlier excluded are now covered. Alternative medicine is covered, Ayush. So treatment through alternative methods is today covered. Infertility, this has been a point of great debate, and there's also a court case in the High Court of Chandigarh, if I recall correctly. And I'm glad to see that there are some companies which offer coverage for infertility as an add-on. Bariatric surgery is also being covered under a couple of products. Also, we have a trend where companies now pay for treatment taken abroad. We didn't have that 5-6 years ago. We have specific products for diabetics, for hypertensive patients, and we also have a few products offering cover for OPD, vaccinations, etc. So I do see a lot of value additions. I believe the health insurance framework has helped in facilitating the development of newer products. But having said all this, let us look at certain indicators today which I think are very relevant in the context of innovation in health insurance. First, infant mortality is coming down. Life expectancy is going up, which means that we have the number of people is growing, which is very good. But when you look at whether we are catering to the needs, the healthcare needs of these people, and whether they are having access and the ability to basically take treatment or get rehabilitation, I think a lot is desired to be done today. What I see is a shift from communicable diseases to non-communicable diseases, and we all know where India stands as far as NCD is concerned. So chronic care has become a very, very important aspect of for the population today. Are our products covering or facilitating financing for chronic care? Also, we are mostly concentrating on tertiary care and to some extent on secondary, but primary care is largely outside the scope of insurance. So this, we all understand, is what we need today. What we can deliberate on today is how can we build these into our products, but without forgetting the fact that these products have to be designed appropriately and priced appropriately, because we are talking of insurance today, and in the insurance industry should remain viable to be able to pay claims under the policies they issue. Having said this, I will now request Dr. Prakash. Sir, as a first standalone health insurer, what's your experience, in the space of retail and state health insurance schemes? How they have evolved, and also how can you bring in innovation in these areas?
Thanks, Madam Priya. Actually, the exposure in implementing state-sponsored health insurance scheme has given us a lot of insight into how we can innovate newer products. At some point of time, we were covering around 12.6 crore population. That's more than 10% of the Indian population through 2 mega health insurance schemes, and with the active participation of 1,000 plus hospitals. So we developed a technology platform, and we do not want misuse in the scheme. And most of our payments were just not activity related, it was outcome based. Subsequent to implementing this scheme, the lessons we have learned, mostly customers' requirement, customers' expectations, we could understand as we implemented this scheme. Before we could implement in 2006-07 through retail business, we had a premium of around 18 crore. And last year we did around 1,472 crore. This means around 90-fold increase in our retail premium we could achieve because of our exposure into implementing mass health insurance program. This is one of the main reasons I can say. See, when it comes to innovation today in our new products, what we understood is, when we covered this mass insurance program, it was like no pre-existing disease. Day one cover, patient can go to the hospital. As Madam was pointing out, the primary care is more of a preventive care. So primary care is given in the primary health centers. So the scheme was covering most of secondary care and tertiary care. And most of these individuals were very happy because there was no information asymmetry at the hospital front desk, because they know the hospital covers, the scheme covers all these procedures, and it was right royally covered. But when in our retail insurance, if you see, we have different products. As she pointed out, there are hundreds of products in the market. Different products have different norms, different sublimits, copays. According to the product, according to the age, according to the premium paid, there are a lot of things customers are not aware, and hospitals are also not aware. So there always used to be a confrontation at the front desk of the hospital when our customer goes with a product. So what we thought, original vanilla products which had exclusion for common ailments for 2 years and pre-existing diseases for 4 years, we thought, this may not be all that welcome by the common man. We cannot penetrate fast if we have to depend only on these vanilla products. That's the reason why we thought we should innovate and cover diseases that are otherwise declined in the industry. The industry declines in general cardiovascular ailments, chronic renal disease, cancer, cirrhosis, COPD. So whatever the industry is apprehended about, we thought that why can't we study it and then try and innovate products to cover these diseases. That is wherein we moved from covering disease to certainty. So we know a person is suffering from diabetes. He has been having diabetes for 2 decades or 3 decades. His blood sugar, irrespective of his blood sugar status, his HbA1c status, irrespective of whether he is taking only oral tablets or insulin, we said that we will give him a cover from day one. Without pre-medical test also, we made this policy available. And the next product we introduced, we reduced the pre-existing disease, the period for PED, the 4 years waiting period for PED. We found that that is a major impediment for a common man when he wants to. Today we had a lot of sessions in the morning where they say that the commercial insurance, social insurance, people who pay from the pocket for insurance premium is less than 6% of the population, so and so. But even this 6%, I will say, most of them are people who have a threat of a disease, or who are at the starting point of a chronic ailment, or who have a strong family history. But what the country needs today is young and healthy people to come forward and have health insurance. Only then, we can address the rising premium. So with the duty of every one of us here to spread the noble concept of insurance. As Chairman IRDA was pointing out, no, we are not using our company fund, it is a pooled fund. We are only custodian of that fund. We collect from money and we pay to the few. And when we pay, it is the non-claimant which is paying for the claimant. So the common man should understand, and young and healthy people should come forward. So our innovation is focusing on young and healthy people to come forward and take a cover, either for them or for their parents. So we have innovated cover to include people who are already suffering from a heart disease. Dr. Puri was mentioning this morning, he had a cardiac event and post-cardiac event, he was declined a cover. We have given a cover, we have designed a cover for people who already have a cardiac disease, who underwent a stenting or a bypass surgery. And after this, if this old gentleman, after 60 years, he has a bypass surgery, and after that, even if he has a fall and develops a fracture of the leg, he will have no insurance cover. He develops a fever, he has no insurance cover because he is a cardiac patient. The industry is declining a cover for him. So we have developed a cover where, a product where a patient who is known to be diagnosed with a cardiac disease and who is suffering from a cardiac disease who has been addressed, we have given a cover. So what I wanted to convey here is the need, the community's expectation is there should be no 4 years waiting period. The specially designed products should be more disease specific, and our unnecessary apprehension on some of the chronic ailments. I'll tell you one example. CVA is a cerebrovascular accident. The industry is apprehended. They say if there is a CVA, we don't cover these people. But The people in the health insurance industry, when they framed this phrase, they probably thought of CVA as something like a person developing a hemiplegia where he cannot use one half of his body. That is what the CVA which they interpreted. But the true medical sense, it is a spectrum of disease. There can be a transient ischemic attack with some weakness which comes and goes. And after that, the patient is totally all right. He just takes some aspirin and statins, so cholesterol drugs. He is also a patient of CVA, but he's totally all right now. So this end of the spectrum we should try to cover. So what I'm trying to, we have to innovate new products. We have to cover from disease to certainty, and we should break our apprehension on some of the chronic ailments. It is a spectrum. At the lower end of the spectrum, there are a lot of deserving people. It's the same way in the mental disease also what they were discussing. There are a lot of diseases which can be covered, and the industry should look at innovating a product that can address all these audience.
Thank you, Dr. Prakash. Sheila, what do you think? What kind of new products do you think should be embracing the market in the near future?
Good, ma'am. I think from morning it's been a good session, and we've had so many discussions on products, and of course on a lot of innovative products that need to come into the market. But as you're reading out, there are a lot of products which are covering most of them. Basically, what we see is that though we innovate new products, the time that is taken between the medical technology that is coming in versus the coverage of it. For example, a non-invasive surgery, or let's take a robotic surgery, today even does not have a cover. So what happens here is that leaves a consumer very grieved, saying, you know, I'm not able to go through this because I'm not having a cover for this. So we just give him a reasonable charge, which is, you know, for a basic surgery. So what we are looking at it is that even at a renewal stage, if we are able to, you know, tell him saying this is what we would cover, so that gap needs to be bridged. And since I'm seeing that we have so many doctors on the panel also out here, and if that gap is able to be, I mean, we are able to bridge that gap quickly, I think that would make a lot of sense for a consumer who's there out in the market, and it will help all of them to get that coverage and avail the medical innovation that is happening in the industry. Of course, we have been talking about OP covers from the morning, and I think the paper that we have released also is on the coverage of OP, which is 60% of thing. On the lighter side, where people don't work for the government firms, when we retire, we don't have pensions and we don't have OP covers. So basically, if the OP cover is there, it makes a lot of sense. But along with the OP covers, we also need to look at saying what we see is that basic, I mean, the highly diagnostic screening. For example, it could be an MRI or a CT scan, which leads a person to get hospitalized. If there is a coverage which is available for this diagnostic things which does not lead to hospitalization, and if that is possible, I think there's a lot of truth that can come out in the industry, and there will be a lot of people who will opt for it, and I think we would always save that money, because today, in order to get that things done, they get admitted. So we end up paying 25,000 rupees, whereas it could just be done in about 5,000 rupees coverage of a CT scan, because there are a lot of diagnostic centers which offer a lot of discounts or facilities that are available now. So I think if this gaps are bridged, I think that would make a lot of sense for the products that come in, and for consumers to look at buying more of health insurance.
Thank you, Sheila. Mr. Anish Kumar, you come with a lot of global experience, and we are waiting to hear from you about what we can look at abroad and adopt from them.
Yeah, so the first point I'd want to build upon is Ms. Bharat's earlier comment that insurance companies in multiple markets have been focused on specific disease states, treatments, and so forth. And definitely in the United States and increasingly in many European countries, the mindset has shifted to becoming a managed care provider where you are paid to keep people as healthy as you can, which is not healthy in every case, because some people inevitably have breakages in the body. But within the confines of science and economics, if you are paid for keeping people healthy, then your incentives and the incentives of the hospitals, doctors, and testing physicians will be aligned. So that's really the one major change that is happening, and from some of the commentary earlier, I believe that there is a similar need here. Framing the so-called insurance companies charter in terms of specific technologies or specific disease conditions is not really the right framing, because you have to look at a whole body perspective. The more medical science advances, the greater recognition there is of different disease states as well as different organs working together. So I think there's that whole body population health perspective. The second point I would make in terms of what's happening internationally is that for many decades, innovation in the managed care sector in the US, for instance, has been relatively slow. It has been a bureaucratic industry. Almost nobody goes to college saying, I'm going to go into the health insurance industry. You end up there, right? So it has been a slow-moving industry. Part of the reason is that the competition has been very country club-like. For example, Cigna, Aetna, Humana, Anthem, these are big multi-billion dollar, multi-tens of billions of dollars type of companies in the US, and they all operate in the same spectrum of performance. What has started to happen over the last 3 years, and we saw this in the panel before lunch dramatically, is that a lot of venture money is now going into information technology, medical technology, to really disrupt this model. And that, just over the last 2 or 3 years, has made us move much faster, and at least the beginnings of a simpler, more transparent, more wellness-oriented solution offering are there. Are we there? Not even close, but we are closer because of these new competitors. So these are the two dynamics, which is really a move toward keeping entire populations healthy, and second, a new class of competition emerging because of Silicon Valley.
Thank you, Mr. Kumar. Mr. Krishnan, your company has been getting a lot of innovations, in particular in the retail space. You have been carrying out a lot of innovations. In keeping in mind OPD and chronic care, let's hear your views on innovation.
Sure. Thank you for the kind words, ma'am. For those of you who are familiar with economics, you'll be familiar with the law of diminishing marginal utility. So forgive me if you feel that what I'm going to say has already been said before, especially given the quality of speakers that we've had before me. So broadly, ma'am, I would characterize, as I see it, and I've seen this industry evolve for close to 9 years now. There have been two categories of innovations that I would credit the industry with. And I recall being in a similar FICCI panel about 4 years ago, and one of the points that was being discussed was, the industry by and large focuses on, Me Too Mediclaim products. And really there's been not that much innovation beyond Mediclaim and variants of Mediclaim. And we discussed that there's a need for segment and segment need specific products. So as Ms. Priya announced earlier, I think there's been an explosion of innovation as far as segment specific products, segment need specific products is concerned. So today you have products that are targeted at senior citizens. You have women specific products. You have products that are targeted at specific health conditions, whether it's cancer, heart disease, or diabetes, as Prakash was saying. You have an explosion in terms of benefits. Now, how many of these are true innovations and how many of these are in the nature of copycats? We can debate, but I think the fact is there is a hell of a lot more choice as far as benefits is concerned to the consumer than there was even 5 years ago, and I think that's to the credit of the industry. And there have been attempts, in terms of outpatient products as well, not too successful so far, but certainly the industry has been moving towards more and more coverage. So that's one big stream of innovations that I believe the industry has been witness to in the last 4 or 5 years. The other one, which is both on the corporate as well as on the retail side, is the increased emphasis on wellness and prevention. So on the corporate side today, and this is again much credit to the industry, certain categories of corporates, certain segments of corporates, it's almost mandatory that they talk about wellness. And I think there's a lot of credit due to the insurance industry. It's not that corporate India was not practicing prevention, not practicing wellness, but I think the insurance industry, specifically the health insurance part, has surfaced this need, put a lot of structure behind it. And today there's a lot that happens in the wellness space in corporate India, as well as in the retail space. So as Ms. Priya was mentioning, there's a lot of companies that are focusing on prevention programs. Almost every product in the industry today has an associated health checkup benefit, which was non-existent for most part 5 years ago. So I think a lot of credit to the industry in terms of doing this. Now, what do I believe is the way forward looking ahead? And I'll focus my answer on what are the needs of the healthcare industry ultimately, the healthcare needs really of the country that the health insurance industry ultimately serves. And broadly, if I look at the burden of disease, I will add one point to what Ms. Priya said, that not only are we grappling with chronic conditions, India is, has the unique distinction of being a country that has the burden of both poor countries. So we have infectious diseases that plague us today as much as you see in sub-Saharan Africa or many poor parts of the world, as well as we have the so-called rich world diseases, whether it's diabetes or hypertension. The other, I think, much underappreciated facet to our healthcare needs is what I would call geriatric care. When you talk of India, invariably you say that it's a young country. It is a young country. We do have the so-called demographic dividend that we are witnessing. But the fact of the matter is, there's more than 100 million people, which is, I tell my German shareholder every time we meet them that we have more than 100 million people, which is 1.2 times the size of Germany, who are senior citizens. And statistics indicate that much of healthcare spend actually happens in the last 2 years of life. And I think there's been very little that either the healthcare industry or the health insurance industry has done, whether it's skilled nursing facilities or assisted living facilities or end-of-life care or palliative care. There's very little that's happened in this space, and I think this is an increasingly important part of what the healthcare and the health insurance industry needs to solve for the country. And what does this mean to the various stakeholders? For government, clearly the arena should be in public health. For healthcare, again, I repeat and echo what Ms. Priya said, that I think the focus needs to be on care. A lot of explosion in healthcare has been around tertiary care and cure. I think there needs to be much more emphasis on care as opposed to cure, specifically when you're talking about chronic conditions and geriatric care. And from an insurance country standpoint, two broad areas that we should focus on, and in partnership with the healthcare industry. Certainly one is chronic condition. I can say on behalf of the health insurance industry, there are a number of products that address this, but these products are not successful as on date. Reasons we can delve into subsequently. And the other is outpatient care. I think over 70 to 80% of healthcare spend is in outpatient, and if we as an industry need to make a meaningful dent in terms of penetration, defined as penetration as a percentage of total healthcare spend, we need to address outpatient. Is insurance the answer? My own personal view is insurance is not the answer, but I do believe that we can play a role in a technology-led administrative solution that we can put in place that helps the outpatient situation. So that's all I wanted to say in this, ma'am.
Thank you very much, Mr. Krishnan. If we look at voluntary health insurance, the major chunk is the corporate or the group health insurance. So let's now hear from Anuradha on what she has to say about how corporate health insurance has evolved and what she thinks the future holds.
Thank you, ma'am. I think just to put things in perspective, with due respects to the industry, based on our research of health insurance policies and prevalence from a general industry perspective, typically the amounts of cover insured with a insurance company, they tend to transfer the risk. Very few self-managed schemes are there. There are only very large health insurance risk portfolios that are self-managed. And if you see, the premiums are probably less than 1% of the gross CTC, and that's typically the experience from a cost perspective to corporates. And 45 to 50% of them provide parental cover. And if you see the cost experience from a corporate standpoint, 60 to 70% arises from dependent cover. And if it's parental, then it actually tilts more towards experience from a dependent cover perspective. And interestingly, 80% of the claims are less than sub 1 lakh. So that's the corporate insurance experience in terms of policy and prevalence. And with due respects to the industry, the value proposition that a health insurance offers is largely still price play. And I have one of my clients who told us that their claim ratios continue to be 160, but they get a price at 100. So that's the value proposition, and I'm sorry to say this in a public forum, but the value proposition play is largely still price. Innovation is definitely happening with due respects to the industry. So from a corporate client perspective, based on our research in terms of issues that corporates are grappling with, are 5 major challenges. One is increasing cost, and when I say cost, the insurance companies may not agree with me in terms of increasing costs. I really look at it holistically because they are incurring costs not only on health but also on well-being. And what we understand based on our research is that companies are spending far more on well-being than on health, which is very interesting. And it's a business priority that they spend on well-being so that employees are productive. And they're not seeing this as a HR priority, but more as a business priority to keep people engaged and productive. And in fact, some of our research show that employee well-being will become synonymous with engagement going forward. So that being the case, the costs keep increasing, and HR is required to demonstrate ROI on health and well-being spend. So that's the first major challenge that clients are facing. So what is that insurance companies can do to help demonstrate ROI on spend? So I think that's the first ask from a corporate standpoint. The second is there are multiple sources of data. The market is so fragmented. So how do companies use this data intelligently? You have a health checkup data, you have a hospitalization data, you have a sickness absence data, then you have a health risk assessment data. There are multiple sources of data. How do I make use of these multiple sources of data in a manner that really is meaningful and helpful to me? And the third aspect is consumer engagement, and that's something that clients continue to grapple with. While they're spending a lot of money, the utilization levels from a well-being standpoint is so poor. So how do you help with that aspect? And the fourth aspect is how do you expand insurance to include a concept of holistic management? And a lot of panelists spoke about it earlier, but I think that's really the need of the hour. While a lot of innovation has happened in terms of well-being and broader management of risk from a health and well-being perspective, there's definitely a lot more to be done. And the fifth and the most important aspect is post-retirement medical benefit. Mr. Krishnan alluded to it. Based on our experience, less than 20%, and even that 20% of companies are probably public sector or government organizations that provide post-retirement medical benefit cover. And that's the major need that employees of companies have, because in a nuclear family environment that we have and we see which continue to evolve, what does that insurance companies do to address this unmet need of medical coverage post-retirement? And can we think about things like health saving accounts, which can help people save money during their active service to be able to draw that down during their retirement period? So I think those are things that can definitely happen. So I think in summary, 3 things from a principles and approach standpoint that I would think the industry should definitely look at. I'm sure a lot of insurance companies are already doing it. Is really one, take a partnership approach. It has to be a multi-year approach. It's a relationship. It's not a 1-year renewable. There's really a need for a partnership approach. And second is really a proactive approach. And when I say proactive, be it in terms of helping manage different sources of data, or be it using predictive analytics. In fact, for one client, we did a predictive analytics based on their hospitalization claims experience, which an insurance company could have very well done. And we told the client that there were a lot of cervical cancer claims. So could you have probably given vaccination to prevent those claims occurring in the future. The well-being is one aspect, but even from a claims data, what is the predictive approach that you can take? So that's the proactive kind of approach that insurance companies should take. And third is really the working on increasing the value perception. So these are the 3 P's that I thought will be very relevant: a partnership, a perception, and proactive approach, which insurance companies need to take. And that's really the way forward that I see. Thank you.
Thank you very much, Anuradha. I think we also got a bonus there. We also had the actuarial perspective coming in. Thank you for that. We've talked about OPD and chronic care, and Mr. Krishnan did give his views. I just wanted to check with the others from the industry in terms of the experience. Can you just quickly share what has been the experience in the current products that cover OPD and diabetes, or conditions like diabetes and hypertension in particular?
OPDs, although with the reservations we are covering in some of our policies, definitely it is a welcome one. People look for it because so 78% of the out-of-pocket expense on healthcare, 78% of the expenses is out of pocket, and most of them like is on diagnostics and OPD. So definitely it is a welcome thing, but the real challenges we have is how to reimburse these OPD claims. And number 2, should we allow this OPD to any consultant, any practitioner, any general practitioner or a specialist, or select network hospitals in our doctors in our network hospitals? So that is the real challenge, And if I identify a specialist or a hospital and say that I will pay for OPD only there, it may not be close to the location of the customer, and the customer will not feel really comfortable. So these are the challenges, but actually we have started and we are experimenting actually. We are experimenting on OPD. In fact, in the diabetic safe policy, we also wanted to pay for the investigations, as Sheila was pointing out. The diabetes, every year they spend some money on basic blood sugar and HbA1c and renal function evaluation. So these things, we want to give an amount for an annual evaluation. And third and most important, we want to give the right. We have created a wellness initiative and we want to give the right information to the customer post-claim. When they get a claim with us, a week after that, we call the customer and we give them relevant information about the diagnosis and the treatment for which the patient was admitted. So this we call as information therapy, like physiotherapy, post-orthopedic problems. This is information therapy, and we find a very great response, and the customers are really happy. And we are also very happy that we could create some sense in the minds of innocent customers. India, the major disease in India is innocence, medical innocence in the minds of people, and that is being capitalized by the industry in different ways. So we are very happy that we are able to give some information therapy.
Thank you very much, Doctor. Health insurance is unique. I always like to say that it's a unique phenomenon because you have multi-stakeholders involved in the delivery of health insurance. So we've now heard from the industry advocates. We've heard from the intermediaries who are involved in sale, etc. Let's now move on to the providers. We are very happy to have with us Dr. Lakdawala and Dr. Nayak. So Dr. Lakdawala, my first question is to you. What kind of medical treatment, in particular surgical treatment innovations, do you think could basically be covered, under medical insurance?
I'll try and put up a presentation. I wanted to be a little different because we are the providers. I just thought I wanted to show you some graphic images, which I just wanted you all to realize, because if you realize that there are a couple of doctors, or maybe 3 doctors here, and most of you all are from the financial world, and to make you understand what exactly we go through when we talk about technological advances and how it benefits our patients, I wanted to show you some of these images. Yeah, this one. Can't see it. So basically, when we talk about advances and all, I think we need to know a little bit of history, because if we don't know our history, we don't really know about the future. So this is how actually medicine and surgery started, from the times when we had to knock out people to try and gain their consciousness so that we could operate on them. There were millions of people who held back people just to operate on them. And these are some of the instruments of the past. As we do know that the only change is constant. And if there is something has to grow, it has to be changed. And that's how evolution eventually comes in. Because this is the surgery of the current day practice. We've got robotics, we've got single incision surgery, which is almost scarless to most people. And we've got notes or natural orifice surgery. So all this is the current surgery. And that's what the consumer or the patient asks us to deliver. Nobody wants all morbid surgeries which involve big open cuts. These are some of the devices that we use in day-to-day practice, whether it's right from the rural villages to the modern-day hospitals that you have. It's all about disposability today, because if we reuse some of these products, you can get harmful infections. We have some of these latest devices which were unheard of 10 years back, which actually changed. Like we said, infectious diseases and things have become a past. So cancers have gone higher and higher because people are no longer dying of infectious diseases. They get living longer, and that's why they're getting more of cancers long term. We have to use some of these staplers and devices, which again become a difficult thing for the insurers to understand, that we need to use some of these expensive products to get them covered. Because yet, I believe so that the government still doesn't puts a tax duty on some of these equipments, and since all of them are internationally delivered to India, they become difficult and expensive to our patients. So in the past 20 years or so, numerous innovations have improved the outcomes and reproducibility of these results. Technology, as we all do know, is getting better and better. In fact, just the other day, we beamed surgery live from Mumbai to Los Angeles, and that's how modern day surgery is today. That's how teaching has got. So therefore, surgery has become much, much safer than it was 10 years back. It's become more patient-friendly. You can walk out the same day after having a major surgery, which was unheard of, and you've definitely got better outcomes than it was in the past. So is this return on investment actually bringing up better outcomes? We do know this was some of the graphic images. This was some of the surgeries done 10 years back. And this is how we used to operate. This is how we were taught. In fact, most of my teachers actually told me that the bigger the surgeon, the bigger the incision. Times have moved on, because that time there was more pain, there was much longer hospital stay, and therefore more cost. There was delayed recovery, delayed return to work, and more dailies lost. And this is surgery today. We almost don't have any telltale signs of surgery with single incision surgery. Surgery's completely transformed itself as of today. And as of the drugs, some of the newer drugs that we use in diabetes space no longer target the pancreas. They actually target the gut hormones. And that's how technology and medicine has moved. We've got lesser pain, shorter hospital stay, and definitely less dailies lost. And therefore, eventually, it would benefit the patients as well. Some of the diseases which were years back only treated with drugs, like diabetes and obesity. I mean, this is the estimated global expenditure on diabetes alone, 548 billion, they say, will be the actual cost. And today, India is second only to China in the number of diabetics. We've got 72 million, and as we count, we've got more and more, 50% undiagnosed with impaired glucose tolerance. USA, as we stand today, spends over 263 billion, okay? And look at India. India spends only 4 billion out of the total number of diabetics, when they have only 1/3 of the diabetics that we have. So a disease which is treated by pills, shots, drugs, today has completely transformed when we talk about metabolic surgery or bariatric surgery. Because today, 90% of this diabetes can be gone permanently if you have. So the only U-turn probably in this disease is maybe metabolic surgery. We have better quality of life improved. We have complete remission of diabetes. But do we give it a chance? Because maybe it's preventive. You might prevent angioplasties in long terms. You might prevent non-traumatic amputations. You might actually prevent a patient from going on to dialysis or getting permanent diabetic nephropathies. But we're not looking at it long term or down the road. We are actually having minimal coverage. And I must credit Dr. Prakash, because he was the first guys to bear the cross and say that, okay, I'll cover bariatric surgery because maybe it will benefit the patients in long term. So there's expense. We always talk about medicine and expense. We never actually question, neither the government nor the public ever questions the millions of dollars or rupees spent on research in space, or we say about protecting lives on the arms and stuff that we do. But we always question every single rupee or every single dollar when we talk about paying extra for medicine. So how does this benefit? Eventually, we are a country where 80% of our population is still poor. Can we give this technology back to the same very people? I believe it is about time, because we need to bridge this gap between this reality of modern day India and rural India to this urban India reality. We've got the, both the ends and spectrums of the world. We need to bridge this gap, because I just saw a sign up that Mahatma Gandhi had addressed this gathering that said the industry, and that by that I mean doctors, payers, everybody included, should regard themselves as trustees and mainly as servants of the poor. So I just want to spin this around in a rather radical thought that let's all of us get to be the modern day Robin Hoods and steal from probably the healthy and the rich, like Dr. Prakash said, and give it to the poor and the sick. Thank you so much.
Thank you very much, Dr. Lakrawala. And now, Dr. Nayak, what are the views of AMC's hospitals and nursing homes on the growth of high-quality healthcare delivery through health insurance, and how do you collaborate with insurers?
I think as far as, Mufazzal has just mentioned about technology having changed and treatment modalities having changed, it is extremely going to be difficult for the insurance industry to factor in all the innovations. And practically, according to me, as of today, it would be impossible for you to factor in all the technological innovations, considering the line of products which are available to you at the moment. For example, it would not be possible for you to factor in a robotic surgery for a hysterectomy, which would be costing on an average 7 to 8 lakh rupees vis-a-vis a normal laparoscopic hysterectomy, which would give you the same results at 1 lakh rupees. So it would be extremely difficult for you to factor in that. But the fact is that you will need to innovate, and that's what he has tried to point out. Let's try and be whether we can think differently, let's think disruptively. So my point which I would like to make here on behalf of the Association of Medical Consultants is that basically we have our grouse with the insurance industry is that you have not kept the any incentive for the insured to keep the costs low. As of today, most of the policies, there are a few policies which have a few minimal percentage of co-pays, but hardly any policies wherein there is an incentive to keep the cost low. For a normal appendicectomy, which could cost anywhere from 25 to 40,000 in a small nursing home, the cost could go up to 1.5 lakhs in a tertiary care hospital. There is no incentive for the patient to see that the cost is kept low, and that he should go to, if it is practical and possible and the risk is low, he is well treated for the same disease at a small and medium healthcare provider at a much lesser cost. So there is no incentive. So there probably will need to be some incentive for the patient to keep the costs low. Whether it's in the form of an incentive, whether it's in the form of a disincentive, that can be worked out. But the incentive could be very much simple. Like, a normal delivery, as I said, in a small maternity home could be around 40,000 rupees, and the same in a corporate hospital could be 1.5 lakh rupees. So if the patient delivers in on a smaller maternity home, it would be, naturally the patient should be given some discount in the premium subsequently. I think this could be one way, or the patient, there could be new policies which could be designed that for a lower premium, you can go only to this small and medium healthcare providers for a particular kind of an ailments. If you have seen the analyze the payouts, there are basically for five major things: maternity, trauma, infectious diseases, cardiac, and malignancy. Of which malignancy and cardiac, I do agree, would be predominantly better treated in a tertiary care level. But infection, most of 95% of the maternity cases, 95% of the trauma, and 95% of the infectious could be managed in a reasonably equipped small and medium healthcare hospital at much lesser cost. But as of today, there is nothing in your policies which is giving him an incentive to go there. Once he has a policy other than the room rent cap of 1% or 2%, which you people have put in your prep, there is no incentive for him to keep the costs low. So there needs to be some way of incentive or disincentive for the patient to try and keep the costs low. Number two, as far as engaging the providers are concerned, I think there has to be a more concerted attempt to involve the small and medium healthcare provider also. I do realize your grouses that this is an industry which is unregulated, which is, not self-disciplined, not standardized. We can understand all these, but these are things of the past. There are groups like ours which have come up, and and have said ki we are willing to become to be standardized, to be self-disciplined, to be self-regulated. So you'll need to engage in with these groups wherein they can provide you at these costs, at a much lesser cost, the same level of the treatment, which could be otherwise what is going to happen over a period of time. Yes, the patient, if he's going to as somebody said, I need the in the morning, she said, I want this thing to talk to me. I want the insurance industry to talk to me. Yes, the patient will demand the moon. But the patient, if she wants a category, we are not saying reduce the choice for the patients. If the patient, he or she wants to go to a tertiary level, she will have to pay out of her pocket. If she has not paid for a higher premium, she will have to pay out of her pocket. So it is her right to go to a tertiary level, but at the same time, as insurance providers, you'll need to factor in your this thing that as of today, in spite of all these of 20 years, we are still at 8% penetration. And unless we bring down the cost of the premium, it's a classical what came first, the hen or the egg. Unless you bring down your premiums, the penetration won't increase, and unless the penetration increases, you will not be able to bring down the premiums, and that will happen only if you are able to bring down the costs. And the way of bringing down the costs is not by squeezing the small and medium healthcare providers, is by in fact encouraging them. I mean, there will have to be discipline amongst the small healthcare providers also. We are open for it, but we are looking to engage you more, of course, with some help from the regulator. We are willing to sit with you and see to it that in what are those conditions which can be ordinarily treated in a small and medium healthcare providers. Let us sit together. Let us see if we can innovate and do this.
Thank you.
This is my opinion.
Yeah, thank you very much, Doctor, for your views. I think it's really true today that wherever we have a small medical problem, we immediately think of the specialist. For instance, just yesterday, my daughter suddenly said, I need to see a dermatologist. And I said, why? And she said, I have this boil on my palm, which I need to show to a dermatologist. So, Dr. Lakrawala, I'd like to have your views on how you think, we should incentivize, or whatever is the word that we should use, for people to visit smaller nursing homes and hospitals rather than going to tertiary, because I think this has a great impact on for the insurance industry.
Ma'am, I think we should take a leaf out of what the NHS does. NHS, even a surgeon, if I want a drug, I cannot prescribe myself. I have to go to the GP first to recommend me to the specialist. I think if we get something like that going, and where the general practitioner who's almost running out of steam gets a new lease of life, and he's been told, okay, insurance guys will pay you an X amount for seeing a patient on outpatient basis. And then he will probably bring the cost down. And he's given us a certain limit so that he doesn't go and over-investigate a patient as well. So for certain investigations, maybe we could have a tier system wherein we could say a specialist is allowed to write a particular level of investigations, a general practitioner is allowed to write a particular level of investigation. And then it gets escalated up from there on. So that a specialist is not allowed to see, let's say, a boil that walks in and sees at his clinic. Something like that.
Thank you, Doctor. I have a couple of more general questions for the providers. We're talking about innovations in healthcare delivery and new treatment methods. Why are they so expensive? I think one is the issue for the insurance industry is one, the expense, how expensive it is, and secondly, when does a treatment actually get established or recognized, generally as an established procedure?
I think, it is as technology advances, for it to be routinely accepted as the gold standard of treatment, it is over a period of time. I mean, it won't happen that this technology has come in today and tomorrow it is going to be accepted as the gold standard of treatment. But laparoscopic surgery 10 years ago was not an accepted gold standard, but today laparoscopic hysterectomy is a gold standard. I mean, the incidences of open laparoscopic hysterectomy have come down by almost, I would guess, at least 70 to 80% with the advent of laparoscopic surgery. So I think it's over a period of time that the health industry will evolve. But as I said, you will not be able to factor in everything. It will not be possible for you, considering the scenarios. The costs of this are, as he said, they are all imported. Most of them are single use. They are supposed to be single use, but in India, jugaad is what we believe in. So the same the gun will be used multiple number of times, and then we say, okay, we have been able to reduce the costs. We have been able to reduce the cost, but with an inherent risk of infections, which is going to be there. So everything will come at a cost. I think one of the statements which I made, if you pay less, you pay peanuts, you will get the monkey. So unless, if you will need to pay for technology, and if you pay for the technology, your premiums also are going to be higher.
I just wanted to add one more thing, is that if it's a consumer market, a patient today is sensitized by media, by marketing from companies like robotic surgery, for example. Like Dr. Sudhir said, it doesn't change outcomes in terms of a hysterectomy. But because it's marketed so well, a patient comes and says, I want only robotic surgery. So whether you can deliver it or not is the question. And insurers will have to decide then whether to pay for it or not to pay for it. Certain things like prostatectomy, there's definitely an outcome difference in terms of robotic or not, but not in all surgeries.
Yeah, I'm Dr. Amitoj, and I have few questions, one or two questions from provider side. One, since the insurance industry has been dealing with the hospitals, and over the period of time, there has been, what we have been witnessing is a trust deficit. Whereas we feel that somehow some treatments which could have been avoided are being pushed into the system deliberately to make profits or whatever. So how to deal with these kind of, I know people here would be of a different school of thought, but the insurance industry is still facing from that I would say it is a stigma, or it is whatever you may call, but yes, the treatments are being pushed, like a knee transplant is being done on a 44-year-old lady. It was like a height of it when we saw that case a few months ago. So what is your opinion on that, and how you are going to regulate such things? And another is the episode of overuse of antibiotics in post-surgery or in infectious diseases, because even the medical industry, medical fraternity is also worried about the overuse of antibiotics in India right now. So it is again a simple antibiotic, amoxicillin or something, clavum can be given, whereas today all the doctors, most of the doctors in nursing homes are using all the kind of third generation, fourth generation, costliest of the antibiotics, and they are bringing up our cost again.
I don't know whom this question was directed to, but if it is directed to me as a representative of the small healthcare providers, I think that is where in the role of such associations, wherein, I mean, internationally if you see, the standards are decided by peer-reviewed bodies. So it is here, we have a body which has decided that there are, NABH has entry-level standards which 75% of the nursing homes in Mumbai will not be able to comply simply because of the physical standards. In Mumbai, the constraint is real estate. The size of the OPDs, the size of the waiting rooms, in Mumbai, an ordinary nursing home will not be able to, will never be able to comply. So therefore, we have decided these standards in association with one of the NGOs. We have come out with these QCI standards, and we have now around 200 nursing homes which are accredited as per minimum standard and excellent standards. So this is one standard which we are willing to share with the insurance industry, and these 400 nursing homes are willing to be self-regulated. They have given us an authority that the governing council of these associations will help the insurance industry to cut down frauds. We do realize there are black sheep in the profession, but there are good people also, and you people will need to identify who are the good people and need to work with them.
No, standards are there. NABH is also working on that, and QCI is working on that. What about the pricing? A simple doctor would go to a nursing home and charge 70,000 for a simple normal delivery. Another would go to the same nursing home, again a gynecologist would charge 20,000 for again same normal delivery. So where's the
I think, if we are talking of standardization of charges, I think that is a gray zone which will be extremely difficult, because these are standardization of professional charges is never going to be an acceptable modality for any professional community, be it lawyers, be it doctors, be any standardization of professional charges won't be possible. But if we are going to talk of, a certain The hospital costs, I think that there is no issues about standardization of that. As we said, we have this protocol where we have divided ourselves into 3 standards in any case, and the industry could look into this and see to it that as per this standard, this is what we could be,
in a
which could be
way,
allowed.
if you can excuse me, like, in a way, it's a very, very significant question that you have asked. There is no, Ms. Priya was also telling us that, there is no regulation for hospitals at present. There is no uniformity of charges. There is no standardization of practices. But 20,000 crore, the premium that has been collected for 2014-15, they say it is expected to reach around 55,000 crore. And this has to be dispensed to hospitals where there is no standardization. That is the biggest challenge. And all insurance companies should come under the ambit of the council or a regulator. They have to arrive at a platform. As you rightly said, the need for antibiotics is highly questionable. The hospitals trying to give multiple antibiotics, high-end antibiotics. The cost of, Dr. Puri was telling this morning, the cost of antibiotics and antifungals for a patient who stays in the ICU for a week, that alone will exceed 2-3 lakhs. The patient has to spend several lakhs when it comes to the need for the knee replacement, whether it is indicated or not. Who decides? The treating doctor decides. But here, I will tell you, ladies and gentlemen, the biggest advantage of one having an health insurance and one going directly to the hospital, the one with the health insurance, there is an electronic second opinion, an electronic authentication and verification done by the insurance doctors. I will not approve a knee replacement for a 40-year or 35-year-old lady without having the proper proof that there is a severe degeneration or arthritis or joint space narrowing, or there is an MRI done, or there is a predisposing disease like rheumatoid which is causing this knee joint problem. Without me convinced about the indication, I will not approve that. This is how, even a simple dengue fever, which is there is an epidemic, people are trying to make a lot of panic out of dengue, and the need for platelet transfusion in dengue, we were trying to send a circular to educate our service providers on what is the real need for platelet transfusion in dengue. But what is currently happening? Hospitals are trying to take advantage, I do not know, on the patient's anxiety, and we have to bear the brunt.
There is one question from my side also. I'm Dr. Rajeshwar Bhardwaj from HDFC Ergo provider side. How we should cope up with the increasing hospital tariffs per year around 30 to 35%. If you say that medical cost, means equipment costs are increasing, I was recently reading an article around 15 to 17 or somewhere it is mentioned as 20%. But how come the total tariff cost, which includes the surgeon charges and the other billing charges, everything including?
Let me add one perspective, sir, to your point, which also goes to the earlier gentleman's point, which is the fundamental framing of how hospitals or smaller clinics are paid is flawed, in my opinion and my experience, where just as the insurance company should be paid to keep people healthy, the delivery system should be paid to keep people healthy. And so if that is done, whether they use high-end antibiotics or not, that decision will reverse itself dramatically in one day. And we've seen example after example of this in developed countries. When risk is transferred to the delivery system, they take the best possible decision. And orthopedics are a great example because they can be carved off into things that people understand, whether it is knee replacement or hip replacement or implants of certain types. Then once you've done that, then what kind of anesthesiologist you use, how much physiotherapy you use versus how much of some other treatment, let the doctors decide that because they are on the hook. So I think that is one point. The second point really was around how much you pay. Today, the consumer does not know that, at least does not know that before they make the purchase decision. They should. This is the only part of the economy where you are on the hook for very large amounts, and then you find out what the bill is. Once you find out, some people will pay the more expensive doctor because the doctor is so good. Others will not, and let 1,000 flowers bloom.
Sorry, I was just asking that question. And the second is that what we are finding these days, these are our observations, that every new hospital which is coming in some area, they are coming the 50 to 60 or sometimes 100% higher rates as per the existing hospitals. When we talk to them, we discuss them, they say, sir, cost बहुत बढ़ गया, instrumental cost बहुत बढ़ गया, surgeon का cost बहुत बढ़ गया. Some of the surgeons are the same, which are working in the previous hospitals and all that. How we can cope up with these problems? On one side, we are thinking that we should increase the health insurance sector, 6%, 8% is there. Second side, we are providing benefits to some typical segment and all that. These are the
You're
points
right.
which
If
should
the
be discussed.
penetration has to increase, health insurance penetration has to increase, it is much more in the hands of the hospitals than in the product designers. Because in the hospital bills should be controlled. Your point is right, but this is very difficult for an individual health insurance or a TPA to handle. That is why, the need for us to stay united under the ambit of the regulator and, form a registry or a council within ourselves and then talk to the hospitals and
Sir,
then
we
standardize
as
the
a-
cost, publish in the website, and then all of us agree and say that we will pay only this much for this
We
procedure.
as an insurer,
Let me
sorry, I interrupted you. We as an insurer need to sit and see, and we can consult with our medical colleagues also. You see, you can see the data either from the West, because he is representing West, so that he will not be interested in coming for the North issues and all that. Everywhere it's the same issue. Hospital rates are increasing like anything. When we discuss with our hospital seniors, they said, no, the cost is increasing like anything.
Yeah,
If you see the same procedure, sorry ma'am, same procedure, and one very funny thing is coming in the market.
I get your point. Let me intervene here. Our chairman in the morning mentioned about Rohini, the hospital registry, which the IIB has just launched. Rohini is just not going to remain a hospital registry. We are going to use that platform to actually evaluate or look at providers further in terms of standards, in terms of protocols to be adopted. On costing, in fact, there was a committee set up by the Ministry of Health and Family Welfare on standard norms for costing. I do agree that you cannot set norms for professional speak, but you can certainly set up norms for what could get into costing, for a particular treatment procedure.
Yes.
So we are certainly moving in the direction. We are conscious of this. As I always keep saying and keep crying, that the bane of the whole health insurance industry and the healthcare industry is that the healthcare industry is unregulated.
Yeah, absolutely.
And you have several things which fall under the ambit of the center, some in the ambit of the state. But as far as the insurance network is concerned, we certainly plan to bring in some kind of benchmarking, some kind of standardization.
That is required. You're
Given the complexity, it requires a lot of deliberation, a lot of discussions, and a lot of that has happened. We have a separate platform called the Health Insurance Forum, which has been set up by IRDA, and all stakeholders from the healthcare industry and the health insurance industry are part of it. So we take your feedback, it's a valid one.
Second, my observation.
Madam, actually,
Can I add something here? I mean, you just mentioned that costs, according to you, are spiraling as far as the hospitals are concerned. I mean, the insurance industry started off with about 42 procedures where they decided that the packages should be offered initially 42, and I guess now it's around 104. I mean, if you see, majority of these the smaller hospitals will not be offering more than 5 to 10. And for them, the benchmark that you could decide is what for this particular package, this is what I would be able to pay for this particular patient when she goes for this particular procedure to a small and medium healthcare. This is what I would be able to give. If the hospital is charging more than that and the patient still wants to go, he or she will have to pay from her pocket.
Sir.
So this will have to be, then the market will decide whether the patient goes to XYZ or ABC. And because then your payouts are decided, what you're going to pay your customer.
I think we are seized of the issue, and we also, you have one second. I think you've had your chance.
I'm Dr. Ajela from Bhopal, and I have 4 points.
That will be the last question. With
One
your
or two
permission.
suggestions, and the rest my experience. Regarding the OPD, as Mr. Prakash has said, I think, and it was started OPD with the health insurance way back in 2002 by one local person as lifeguard. He started this policy with the OPD with OPD inclusion, and finally he disappeared with all the money of the hospitals, clinics, and the insurance persons. This is because the claim ratio is very high and you cannot regulate OPD. Till you cover 50% of the total population with the insurance and till you bring down 50% of your claim ratio, I think no insurance company should add OPD treatment because it cannot be regulated, it cannot be monitored. It is very difficult. It will be very difficult whether it is inside the hospital or it is outside the hospital. And the moment the claim ratio will go up, how you will decide that this is a real OPD patient or it was a fake OPD patient? Because as I'm running a hospital, previously patients used to come, Diwali aa rahi hai, I have to buy a fridge, so make a bill. You
Okay,
take
I get
something.
your point. I think it's
So
a very important.
this is the mentality of the Indian
The
Indian
important
people.
point you raised, sir, is about fraud. I think it's a very, very important aspect in particular in health insurance, fraud and overutilization.
And secondly, the number of service providers. What is happening in the health insurance? You are not measuring the quality. Anybody who is applying for the to be in the network provider list, they are included.
It's not really the case. The industry does have its own.
You should have some certain benchmark like NABH entry level or something like that, because that decides the quality and that decides the pricing also.
That's precisely what I mentioned when I said that we will be getting into laying down certain benchmarks and standard. Thank you very much.
And one thing to Madam Sriram.
We have another question there. Is there anything?
Just thing, because regarding the corporate clients, the corporates who are getting services in the corporate sector, their parents are also included in the most of the policies, and they are the persons who are claims bringing down the ratio, because there is no pre-existing, all the pre-existing diseases are covered in the corporate clients of the aged persons. That is why the ratio is going up in the corporate sector.
Right, sir. Thanks.
No, for your information, corporate sector maximum claims are maternity claims. 15% of the claims, 15 to 17% of claims are from maternity. They're not parental claims.
No, madam, we are running the hospital, we are having parents
during
also.
Coffee break, sir. Yeah.
Thank you very much for a very stimulating discussion, and I think covering a complete range of perspectives from different players from the industry. You know, we began with the theme that think disruptively, and when you look at it, you begin from a set of points, which is all music to my ears. I'll tell some of the keywords which came to mind. We talked about chronic disease care, we talked about geriatric care, we talked about whole body perspective, we talked about employee well-being, we talked about holistic health management. And where do we get all this together, right? And we still go back to surgery, right? We look at our preoccupation with surgery so much that insurance and different types of surgical procedures. Do we look at, is there some disruption really possible, going beyond OP care, but at chronic disease care? Secondary prevention, the nipping in the bud diseases which are surely going to become a major emergency intervention. So if you look at this entirely, there is a new class of healthcare organizations which just don't come into the discourse, and which is, you know, quality systems driven Ayurveda organizations. I know I'm talking completely at variance with the stream of thought here.
Alternate
but
treatment.
you know, when you even the use of the word alternative medicine sounds very, you know, patronizing, because it is a system. In fact, the father of surgery is Shushruta, not, you know, so it begins right from there. And having said that, we have NABH accreditation, we have all of that now prevalent in Ayurveda. I would only want to ask two things. One, what do you believe prevents Ayurveda from getting more widely accepted? And number two, how do we ensure that the insurance sector creates an enabling framework to attract good quality Ayurveda hospitals to come in greater numbers? Please remember, 12,000 doctors pass out every year. It's a large community coming in who can contribute to the overall healthcare provision. So from insurance sector angle, how can we play a better role in supporting and complementing what is already there on the ground?
I'm glad you raised that, sir. Maybe I will rephrase, and instead of using the word alternative treatment, I will use Ayush, not just Ayurveda. I'm going beyond Ayurveda. I'm going to Unani, and I'm going to everything else that is contained in Ayush. So from the regulatory perspective, the first thing that we have done, I mentioned the health insurance regulations. We have specifically brought in a provision which says that insurers, you know, should offer. We haven't said should offer, but we have encouraged them to offer. And secondly, in order to ensure that we don't have the fly-by-night operators, we've clearly said that they should be registered with either, the respective council that is there. And on a practical note, let me just tell you the products that I have been receiving at the regulator's office for clearance more and more offer coverage for Ayush. And let me also tell you that wherever they try to offer restricted coverage, where the treatment is as a result of Ayush and not allopathic treatment, I have not allowed any restrictions. For instance, there are insurers who have filed and said that if the treatment is, through Ayush, then it will be only 10% of the sum insured or 20%. I have said, hey, if you offer it fully. Give the insured person a choice to choose the line of treatment and cover him or her fully. I'm not saying that that is the end of it. These are certainly proactive measures, but we take your point and we will definitely work on that. But I think that would be the last of observations or questions that we would be able to take. I have a selfish motive here because I have a flight to catch back to Hyderabad. And I think I am not too early and not too late quite on the dot, but I will just take a second or two to wind up. I just had certain points that I feel we should mull over while we are discussing design of insurance products. It might sound cliche from an insurer, practitioners plus or regulatory point of view, but while we work on product design and innovation, we cannot see it in isolation of the delivery system, the sales system. So we have to look at innovation and business model as a whole. And today, for instance, if you're delivering through internet, it's very much part of the product design itself. So we'll have to look at it, holistically, number one, and number two, make maximum use of technology, because it not only makes it, faster and more efficient, but also cost-wise, it helps reduce cost. And finally, I just want to mention that while we design new products and while we want to cover more and more things that are today excluded, let us not forget the basic principles of insurance. No doubt, the principles of insurance are getting modified, but let us go back to our first lesson that it is basically a pooling of risks, and it is out of that pool of money that we are paying out claims. So let us design products in an appropriate way where we are taking on risks for the unforeseen events, number one. And number two, price them adequately, because we just don't want a situation where we are collecting premium and issuing policies and insurance companies are not in a position to pay them. So we need to strike the right balance. With that note, I'd like to thank FICCI for the opportunity and all of you for patiently participating in the deliberations. Thank you.
On behalf of the panelists, I think we need to thank our moderator. She has done an excellent job. A big round of applause for Madam, please.
Thank you, panelists, for an engaging session.